Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Stephanie Desmon talks to Dr. David Newman-Toker, a Johns Hopkins neurologist who studies diagnostic errors. An estimated 795,000 Americans die or are permanently disabled by diagnostic errors each year, which Newman-Toker calls a public health emergency. They discuss what can be done to prevent some of the most serious errors. Let's listen.
David Newman-Toker, thanks so much for joining me.
Thank you for having me.
So today I want to talk about your area of expertise, which is medical diagnostic errors, and you've recently called them a public health emergency. Could you please elaborate on that?
Sure. I think a lot of people in the patient safety and quality movement haven't necessarily used that framing, but I think it's important that we do. And the reason why is because we've estimated that there are about 800,000 Americans who suffer death or permanent disability each year, many more worldwide, no doubt, as a consequence of missed opportunities in diagnosis and failure to intervene and treat conditions that patients have, particularly for dangerous disorders. And that doesn't even count some of the lower level chronic morbidity associated with misdiagnosis of chronic illness.
So why is this happening?
It's a great question. At some level, the reason why it's happening is because diagnosis is hard. There are more than 10,000 different diseases, and they manifest with dozens or maybe even hundreds of potential symptoms or symptom complexes. It's really beyond the capacity of any one individual clinician or even teams of clinicians in many cases to get to the right answer on a consistent basis. But that doesn't change the fact that there are clearly opportunities where we could be doing better than we're doing right now. And the reason why we haven't capitalized on those is because our whole system is really oriented mainly towards treatment and treatment of more serious forms of illness, particularly in the hospital. And the ability to recognize early manifestations of disease is not something that the health system has emphasized. And that's really where we need to refocus some of our attention.
So what we're saying is that these are preventable?
I do believe that they are. When we did our estimates of the public health burden, we used studies. We brought together different pieces of information from different parts of the literature. There is no one unified locus of being able to kind of measure the overall impact of diagnostic errors. But what we did was we took a disease-based approach where we identified essentially the disease incidence or frequency of the disease, multiplied that by the frequency with which errors occurred, and multiplied that by an estimate of how often those errors resulted in harm for that sort of disease. And then we added them up across diseases. And in the case of the error rates, we used numbers that were believed to be preventable misdiagnosis rates. And overall, those were for dangerous diseases on the order of magnitude of 10%. What we're saying there is that if you have a dangerous or deadly disease, such as stroke or heart attack or pneumonia or meningitis or lung cancer or breast cancer, there's some chance that we will not recognize it early on when there was an opportunity to do so or potential opportunity to do so. And as a consequence, generally speaking, you go on to suffer the harms from the disease itself. Occasionally, there are also types of harms that result from patients who are given a diagnosis and given an inappropriate treatment. So, for example, we have one patient who was diagnosed as having metastatic breast cancer who received chemotherapy for many years, and it turned out that they didn't have metastatic breast cancer. They had sarcoidosis, a lung disease that looked on x-rays like metastatic breast cancer that had spread to the lungs. But those kinds of harms were not counted in this study in the 800,000 estimate. We really looked at what happens if you have an aortic dissection, which is a very lethal illness if it's not diagnosed within a few hours. How might we reduce the mortality from a disease like that if we made the diagnoses earlier? And all of the studies that we looked at this question of just how much faster we could have made the diagnosis in theory. So we do believe that these are preventable.
What is the most preventable?
I think it's important to think a little bit about how we might view preventability. So we've seen that across the diseases, there are different rates of error. The lowest rates of error happen with heart attacks, and we do actually remarkably well with those. We miss about 1.5% of heart attacks, and patients being harmed is less than 1% of all this. So if you do have a heart attack, there's less than 1% chance that you'll be harmed from a missed diagnosis. That's almost the shining star example that we can say, okay, look, we that didn't happen by accident. We spent decades developing good tests, EKGs, blood biomarkers, creating pathways of care, monitoring the quality of the accuracy of our ability to capture heart attacks in chest pain care pathways, and slowly but surely making part of our regulatory and payment apparatus that we deliver that care at the highest possible level. Emergency departments are monitored for how quickly they get patients with heart attack to an electrocardiogram, for example, and they have to do so within a short period of time because otherwise those patients could die. We have not applied that same level of rigor and effort and research to a lot of these other conditions. For example, spinal abscess, we miss at a rate of about 55 to 60%. This is a disease where you have an infection around your spine, and if you don't diagnose it early, you can either die or be permanently paralyzed. That's a disease that's rarer than heart attack, but it still presents with clear manifestations. And when we look at the misdiagnosed cases, almost all of them have what we might consider clear signs that this was not just a routine case of back pain or neck pain, that in fact there was a clue that something else was more seriously wrong. So we have some combination of diseases that are relatively uncommon and misdiagnosed at very high rates, and those that are more common and misdiagnosed at sort of intermediate rates. I think stroke is a good example because it's as common essentially as heart attack. So over 1 million people a year, if you count strokes and transient ischemic attacks, the pre-strokes, if you will. And yet we misdiagnose it about 10 times as often. We miss about 17% of strokes as opposed to 1.5% of heart attacks. Now, why is that? Well, it's a little harder maybe to diagnose. Some more complex presentations. Sometimes people present with much more varied symptoms. In heart attack, maybe they present with just chest pain and back pain and nausea or some limited or fainting. And in strokes, they can present with any number of symptoms: numbness, weakness, dizziness, double vision, headaches, etc. But there's still common themes that we miss certain types of clinical presentations. And this is a kind of a critical issue, is that we don't miss diseases when they're obvious. We miss them when they're subtle. And that sounds silly when you say it because it seems self-evident, almost a truism that would be the case. But take stroke, for instance. We don't miss strokes when people present with clinical symptoms of being paralyzed on one side and inability to talk. We miss strokes when patients come looking like something else. So they have dizziness and it looks like inner ear disease, or if headaches and it looks like migraine. And the critical issue is, if we're going to fix this problem at a broader level, we're going to have to do it by tackling those subtle clinical presentations, not simply by focusing on the ones that we already do well.
I mean, I've been in an emergency room in the last 6 months, and I know that the waits can be incredibly long. For example, like I waited 10 hours and never saw a doctor. If something was happening to me, that would not have gotten any attention, even if I was presenting with, it was a fall, and no one saw me.
Well, this is a major issue, particularly a major issue now post COVID-19 pandemic, where there's been a significant exacerbation of overcrowding and hospital boarding issues in the emergency department, that where essentially patients are backed up and they can't get admitted to the hospital because there's no room and no bed in the hospital. This is creating a lot of people waiting. The waiting area in an emergency department is an important place where diagnostic delays occur. And some of that is just because the system is overwhelmed. And we need to fix those systemic problems with the way the emergency department and other places function in the hospital. But some of it is because we're not effectively identifying at the front desk, at the triage desk, who's at risk. So if we could do a better job of diagnosing patients when they walk through the door. So for example, chest pain patients go right to the front, if you will. There's a pathway and a protocol for getting them in. Dizzy patients don't. They only go to the back if they have specific stroke symptoms or signs, and instead they go to the waiting area. And we've developed a clinical service at Johns Hopkins Hospital that we call Teledizzy, where we do remote subspecialty teleconsultations on patients with dizziness and vertigo, in an effort to reduce the wait times to diagnosing stroke and to improve our accuracy of diagnosing those patients and not sending them home inappropriately, as well as to increase the accuracy of diagnosis and treatment for the patients who don't have stroke, who often get unnecessary workups and evaluation. And what we've found is that there are often patients sitting in the waiting room where we found a stroke patient the other day who had been there for 8 hours, and essentially no one had known that this was a stroke syndrome. And these are, critical, when we're talking about stroke and time is brain, these are critical minutes, seconds, minutes, hours, et cetera. And this is true for many different diseases. So we do have to find ways to improve the pace with which we identify high-risk patients and differentiate them from low-risk patients. Right now, our mechanisms for doing that are a little bit on the crude side, and we are really good at detecting people who are physiologically very ill, who have obvious changes to their blood pressure is way too high or way too low, things like that we're very good at sort of ferreting out at the outset of an encounter, but not so much for that sort of next rung down of people who have the early manifestations of a disease that they're going to look that sick in a few hours, but they don't look that way now. We're not as good with that.
So you spend a lot of time researching this. So where should research focus going forward?
I think we're at a stage where really what we need to do is start identifying key targets for reducing diagnostic errors and showing the benefits. I do believe that there are some hotspot areas where we could probably make improvements. I think at some level, probably the core theme in these cases is to improve access to expertise, because these subtler clinical presentations that get missed are often recognizable as patterns that people who see that thing all the time recognize, that may not be so for people who have a broader pot of symptoms or problems that they have to deal with. Specialists who may have access to a narrower pool. For those of us, for example, who do diagnosis of patients with dizziness, it's fairly straightforward because all we do is see dizzy patients all the day, but it may not be so for somebody who's in general practice. And improving the access either to human experts or encapsulating that expertise in technology in the form of diagnostic decision support, artificial intelligence, et cetera. Improving the way that we train people to become expert in specific areas where we know diagnosis is not necessarily accurate, and making sure that we provide mechanisms for feedback so that people's diagnostic skills improve over time. These are what we call the 4 T's: teamwork, technology, training, and tuning. And I think these are important areas for us to think about solution making and for doing studies that show, hopefully, that we can reduce the harms, improve diagnostic accuracy, and reduce harms associated with diagnostic error. I think those are the critical areas, but I do think it's crucially important that we recognize that right now, this is a dramatically underfunded research effort. In fact, it is the most underfunded public health problem in America. If we look at certain conditions, there are some diseases where we spend approximately $400,000 per death at NIH. On this diagnostic error problem, we spend approximately $50 per death. The amount of research funding that's supporting this issue right now is probably somewhere in the $20 to $30 million per year range. That's less than we spend on smallpox research at about $39 million, a disease that was eradicated half a century ago. Mm-hmm. So there's clearly a mismatch between the public health severity of the problem, the public health crisis, if you will, and the research dollars being applied. And I do think that some of the awareness building around this is really about raising the profile of this issue to the point where we can do those studies that get us to that point of implementing solutions.
David Newman-Toker, thanks so much for joining me.
Thanks so much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.